Hi, my name is Dr. Mohammed Nadeem. Today my topic is pathology of appendicitis. Appendicitis is caused by obstruction of the appendiceal lumen from variety of causes. Independent of etiology, obstruction is believed to cause an increase in pressure within the lumen. Such an increase is related to continuous secretion of fluids and mucus from the mucosa and the stagnation of this material. At the same time, intestinal bacteria within the appendix multiply, leading to the recruitment of white blood cells and the formation of pus and subsequent higher intraluminal pressure. Technetium-99 radionuclide scan of the abdomen shows focal uptake of rebel white blood cells in the right lower quadrant. If the appendiceal obstruction persists, intraluminal pressure rises ultimately above that of the appendiceal veins, leading to venous outflow obstruction. As a result, appendiceal wall ischemia begins, resulting in a loss of epithelial integrity and allowing bacterial invasion of the appendiceal wall. Within a few hours, this localized condition may worsen because of thrombosis of the appendicular artery and appendicular vein, leading to perforation and gangrene of the appendix. As this process continues, paraappendicular abscess or peritonitis may occur. The most common causes of luminal obstruction include rheumatoid hyperplasia, secondary to inflammatory bowel disease, infections more common during childhood and in young adults, fecal stasis and facalities, which are more common in elderly patients, parasites in eastern countries are more rarely foreign bodies and neoplasms. Facalities form when calcium salts and fecal debris become layered around a nidus of insatiated fecal material located within the appendix. Rheumatoid hyperplasia is associated with various inflammatory and infectious disorders, including Crohn's disease, gastroenteritis, amoebiasis, respiratory infection, measles, mononucleosis, obstruction of the appendicitis has less commonly been associated with bacteria like Yersinia species, adenovirus, cytomegalovirus, actinomycosis, mycobacteria species, histoplasma species, parasites like Schistosome species, pinworms, Strongyloides, Stercoralis, foreign material, shotgun parrot, intrauterine device, tongue stud, activated charcoal, tuberculosis, and tumors. In the USA, 250,000 cases of appendicitis are reported annually. Appendicitis occurs in 7% of US population with an incidence of 1.1 cases per 1,000 people per year. Current annual incidence is 10 cases per 100,000 population. Some familial predisposition exists. The incidence of acute appendicitis is probably lower in Asian and African countries because of dietary habits of inhabitants of these geographic areas. The incidence of appendicitis is lower in cultures with a higher intake of dietary fiber. Dietary fiber is thought to decrease the viscosity of feces, decrease bowel transit time, discourage formation of fat rifts, which predispose individuals to obstruction of appendicitis. The incidence of appendicitis is approximately 1.4 times greater in men than in women. The incidence of appendicitis gradually rises from birth. The mean age when appendicitis occurs in pediatric population is 6 to 10 years. Young hyperplasia is observed more often among infants and adults and is responsible for increased incidence of appendicitis in these age groups. Young children have a higher rate of perforation with reported rates of 50 to 85%. The median age at appendectomy is 22 years. Although rare, but neonatal and even prenatal appendicitis had been reported. Appendectomy carries a complication rate of 4 to 15%. The goal of the surgeon is to make accurate diagnosis as early as possible. Delayed diagnosis and treatment account for much of the mortality and morbidity associated with appendicitis. The overall mortality rate of point is 0.2 to 0.8%. The mortality rate in children range from 0.1 to 1%. In patients older than 70 years, the rate rises about 20% because of diagnostic and therapeutic delay. Appendicitis perforation is associated with increased morbidity and mortality compared with non-perforating appendicitis. The mortality risk of acute appendicitis is less than 0.1%. The risk rises to 0.6% in gangrenous appendicitis. The rate of perforation varies from 16 to 40%, with higher frequency occurring in young age group 40 to 57%. And in patients older than 50 years 55 to 75%. In home, misdiagnosis and delayed diagnosis are common. Complications occur in 1 to 5% of patients with appendicitis. Thank you.